The National Coalition for Cancer Survivorship advocates for quality cancer care for everyone touched by cancer. Founded by and for cancer survivors, NCCS defines someone as a cancer survivor from the time of diagnosis and represents the millions of Americans who share a common experience, living with, through, and beyond a cancer diagnosis. In Cancer Convos, NCCS talks with survivors, advocates, caregivers, providers, and health policy experts about survivorship advocacy and public policy. For more information about NCCS, visit our website at canceradvocacy.org.
Hello, everyone. Thank you so much for joining us during these difficult times. I'm Shelley Fuld Nasso, CEO of the National Coalition for Cancer Survivorship. We know that this pandemic is unsettling to everyone, and we hear from cancer survivors that they feel both uniquely challenged because of concerns about their risk, and also in a strange way, uniquely prepared for this time because of what they have endured through their cancer experience. NCCS has been collecting questions from patients and survivors on the coronavirus crisis, and we decided to address these questions through a series of webinars and podcasts. We knew exactly who we wanted to be our first guest speaker in this series. Dr. Otis Brawley is a Bloomberg distinguished professor at Johns Hopkins University, an oncologist, and an epidemiologist. He's also a truth teller, a mythbuster, a straight shooter, and an all-around nice guy. When we called him last week to ask for advice on how we can best serve cancer patients during this scary and unpredictable season, his response was simple: just be honest with them, he said. We've had an overwhelming response to this webinar with almost 800 people registering, including survivors, advocates, healthcare professionals, and public health officials. That tells me that there's a hunger for more information and that Dr. Brawley is just the person to help us. We thank all of you for joining us for this important conversation as we all navigate through these uncertain times, and we hope that today's webinar addresses some of your questions and concerns. Now I'm going to turn over to Dr. Brawley to make some opening comments.
Hello, thank you, and I really appreciate the invitation. The NCCS has been so good to me and so important to me in my career over the years. It's an honor to be asked to do this. I'd like to talk just for a few minutes to try to bring us all onto the same page about what's going on with the coronavirus and possibly ask a few questions that I know a lot of people have out there, and then we can open it up perhaps for discussion and more questions. But the COVID-19 disease, that's the name of the disease, COVID-19, is actually caused by the SARS-CoV-2 virus. Occasionally, some people will see SARS-CoV-2 and think, are we talking about a separate disease? No, that is the virus that actually causes the disease. It's an RNA virus that you've heard of DNA and RNA. This is an RNA virus. It comes from animals. We call them zoonoses in the medical literature. There are actually many coronaviruses out there. Many of us have had coronaviruses and we just thought we had a cold. Indeed, some people who do well with the COVID-19 virus may do well with it because they have had previous exposure to coronaviruses and it causes a partial vaccination, so to speak. We're currently in a pandemic, which means that there's an epidemic throughout the world. This is not the first pandemic of a virus that we have had. Indeed, we've had 4 pandemics over the last 100 years. This is the first pandemic with a coronavirus. Previous pandemics have been with influenzas. Many of you are very familiar with the Spanish flu, which occurred from 1917 to 1919 and killed between 50 and 100 million people worldwide. By the way, the Spanish flu started in Kansas. It crossed over from horses to some U.S. soldiers who went to Europe and spread it throughout Europe. It was discovered first in Spain, but it actually came from Kansas. You're also probably familiar with the several swine flus that we've had over the years. There was one from Hong Kong in 2009, one that actually killed 4 million people in 1968, previous one in 1957. The way that you catch this coronavirus has been talked about an awful lot. It involves people not inoculating their eyes, their mouth, or their nose with the virus, picking it up off of a surface from their hands or breathing it in from the air. It's become very clear in the last several weeks that people do put the virus out of their mouth through talking, through singing, through coughing. Actually, the virus is much more fine particles when it comes out through talking versus through coughing. And then other people can breathe the virus in. That brings us to the mask issue. The N95 masks that many people use in hospitals, many healthcare providers use, EMS use, for example, those masks actually can protect the individual from breathing in the virus. The normal paper or cloth mask that we use in the operating room or that people will use out in the public, that actually prevents the wearer from sending more particulates out into the air that other people can breathe in. And so the way to think about this recommendation recently for wearing a mask is the assumption is the person wearing the mask may be spreading the infection and the mask prevents the spreading of the infection. It doesn't protect the person who is wearing the cloth mask. One of my colleagues actually said not wearing a mask in public is not suicide, it may be homicide. Who is at risk for this disease? The immunocompromised, certainly people who have lung disease like COPD and asthma, people with diabetes, people with bad cardiac disease like congestive heart failure. We have some evidence that people who have hematologic and lymphoma, hematologic diseases and lymphoma, leukemias and lymphoma, are at higher risk than people who have solid tumor diseases. However, there is some data from China that people with GI and lung cancers and people with metastatic disease were at both higher risk of getting the disease and higher risk of not doing well from the disease compared to the normal population. It is clear that older people are more likely to get the disease and do badly compared to younger people, but that does not mean that younger people do not get the disease, and that does not mean that younger people don't do badly with the disease. Older people are more likely to get the disease and more likely to do badly. Now, the symptoms of the disease are typically a cough, sore throat, sometimes shortness of breath. There are people who have this as only an upper respiratory infection and not a lower respiratory or lung infection. Also, interestingly, there's a group of people who have been diagnosed purely because they've had diarrheal episodes. There is a GI upset stomach component that involves diarrhea and abdominal pain and no respiratory problems in some people who have been diagnosed with the disease. And the most interesting symptom that some people have as an early sign that they have the disease is a loss of taste and loss of smell. Many experts are now of the belief that perhaps half of all people who get infected with the coronavirus, this COVID-19, have no symptoms whatsoever, and they may be totally asymptomatic, walking around, shedding the virus. One of the reasons why the recommendation for wearing masks nowadays. The people who get symptoms from this disease typically get symptoms 4 to 6 days after an exposure. It can be as long as 13 days after, hence the 14-day isolation after an exposure that was very common several weeks ago. Don't hear that talked about as much now, but it's still out there and still should be done. The most common worst day for people who get symptomatic is day 10 to 12. Some symptomatic people are sick for 21 days. The sickness involves, when it gets into the lungs, it's when it becomes really a problematic disease. And it can involve cardiac problems, respiratory problems, a cytokine storm where people start having their immune system just go haywire and go crazy, an acute respiratory distress syndrome. There can also be secondary pneumonias caused by bacterial infections. The initial World Health Organization test, by the way, picked up some coronaviruses that were not COVID. COVID-19 and actually identified some people who had had other coronavirus infections. There was a Korean test that was very similar to the WHO test. And you might recall that Vice President Pence rejected the WHO test and said that we would establish our own test. The CDC test was ultimately disseminated and was rejected by a number of health departments, local health departments, state and county health departments, as having a high false positive and high false negative rate. There's a second CDC test that was very labor intensive, required that samples be sent either to Atlanta or Seattle for analysis. And that's what led to some people being tested and then having a 5 to 10 day wait to figure out if their test was positive or negative. I have much more hope for what's come out recently as a 15-minute test, which still needs to be distributed around the country. It uses the same machine that many doctors have in their offices already to test for strep throat, just uses a different cartridge to test for coronavirus. There's been a lot of interest in treatment of this disease. You know, we have very few viruses for which we have medical treatments. HIV was really the first virus where we started actually having a number of drugs that are useful in treating the disease. There's been a lot of interest in hydroxychloroquine, which is used to treat malaria and lupus. There was a French trial that involved about 20 patients in an intensive care unit, and they said that hydroxychloroquine and azithromycin, an antibiotic, the Z-Pak, decreased viral load. I should point out that trial did not say that the patients did better. The trial said hydrochloroquine was correlated with a decrease in viral load. It was not a randomized controlled trial. It was only about 20 people in it. And those of you who watch Twitter overnight will know that the journal that published that paper retracted it yesterday. The International Society of Antimicrobial Chemotherapy retracted the paper about hydrochloroquine. There are about 100 candidate drugs out there. I would consider hydrochloroquine to still be one of them. And we really do need to do good clinical trials to figure out which drugs work, which drugs do not work. And we need to be careful that we don't waste resources while we try to figure that out. I can recall when ZMapp was thought to be a really great drug for the treatment of Ebola, and when it went into clinical trials, it actually failed. We also, by the way, have some hope for remdesivir, the Gilead drug that's used to treat HIV, but they all need to be tested. Those of you who've known me over the last 30 years remember in my early life, I was a drug developer. I did a lot of work in anti-cancer drugs. And I will tell you, we have had drugs that we thought were great and we gave them to people and they actually died, not of the disease, but because they got the drug. Now with this disease, 80% or so who get infected and get symptomatic do very well, don't go to the hospital. It's only about 20% of people who get symptomatic who go to the hospital. Since we don't have good screening for the test, for the disease around the country, I can only say 20% of people who get symptomatic end up going to the hospital, and less than half of them in near respiratory arrest or respiratory arrest requiring a ventilator. And in the United States, it seems to be about 2% or less of people are dying from the disease. In China and in Italy, it was about 10%. In Germany, it's about 1%. I should also tell you that of the people afflicted with the disease and doing badly, there seems to be a slight preponderance, 60 to 70% are men. Also, there's some studies, I already mentioned cancer patients already. In China is actually the best studies looking at people who have cancer. And they noted that lung and GI and metastatic patients who get this disease tend not to do well. And The last thing I'm going to talk about is the rationing of care. Actually, I'm going to talk about two things, rationing of care and cancer patients still in treatment. Cancer patients still in treatment first. Many of us, many hospitals are not doing adjuvant chemotherapy for breast, colon, and lung cancer right now because we have done a weighting of what's the odds that this chemotherapy is going to prevent the person from relapsing in the future versus the odds that it's going to increase their chances of getting coronavirus and having a bad outcome today. And keep in mind, if we lower their white count and they get coronavirus, that is a ticket to not doing well with the disease. And so many hospitals are only giving, or clinics are only giving chemotherapy to people who truly need chemotherapy right now. Now, one last note on rationing of care. The governor of New York has actually, I think, been very, very good in talking about the fact that our healthcare system normally runs at 95% capacity. A good, well-running hospital in the United States has 3 to 5% of its beds empty. That's in normal times. We are at a point where we could easily be overrun with people who have coronavirus, people who are really deathly ill, people who need ventilators. And none of us want to be in a situation where someone needs to go on a ventilator and we deprive that individual of the ventilator because we have simply run out. That did happen, by the way, in Italy. It has also happened in Spain. In Italy, they literally, in parts of Italy, developed protocols where no one over the age of 50 was offered a ventilator. No one who has a comorbid disease was offered a ventilator. A 30-year-old with a history of type 2 diabetes was not offered a ventilator. Those people were treated with supportive care, which usually just simply meant injection with morphine. Now, I will tell you that the best studies to date of people who go on ventilators show that 35% actually come off the ventilator alive. In the United States, there's one study that says it's 20% right now, but there are some German and some Spanish studies that suggest it might be 1 in 3 people survive the ventilator. This is a really difficult time. My recommendation to anyone who has cancer or anyone who lives with someone who has cancer is to stay indoors, stay away from other people, do all the things that we've been talking about, hand washing, 6 feet, avoid people by 6 feet if you have to go out. Indeed, we all need to try to be supportive of each other and try to prevent the spread of this disease until we can come up with some type of a vaccine which would be useful in preventing people from getting sick from it. I do have some hope that we will be able to develop a vaccine and distribute it, but I suspect that it's going to be sometime early in 2021. And so I'll stop at that point. Do you have questions for me?
Thank you very much, Dr. Brawley. Yes, we have a lot of questions for you. So if you have questions, you can use the chat or question box to enter your questions. We also asked people when they registered if they had questions. So we've collected a lot of those questions. So the question that we saw the most in a variety of different ways from many registrants is about risk. So if are cancer survivors at greater risk, even after treatment, or suffering worse effects if they get it? And then how does the type of cancer or treatment modality and length of time from treatment matter in assessing risk?
This disease is so new, no one has definitive answers to those questions. Those studies have yet to be done. And indeed, we need to study those over time, and we need to study cancer patients who get COVID, non-cancer patients as well, who get COVID and who do well. Because do they have sequelae? For example, in the 1917 to 1919 Spanish flu, people who got that had a higher risk of Parkinson's disease as they got older. But the answer to your question is we don't know. The Chinese have told us that people who have hematologic disease that's active don't do well when they get infected. I am personally very concerned about people who got adjuvant chemotherapy for breast cancer or colon cancer a year or two ago and have finished that. We know that their immune systems are still damaged and have not totally recovered from that adjuvant chemotherapy. So I worry about them, but I have no data on them. I don't think anybody has data on them.
So in the absence of data, then how should survivors who are post-treatment, who may be a year post-treatment or 10 years post-treatment, think about this? I mean, you said we should all be doing the social distancing and staying indoors. Is there anything else they should do? And I think that a lot of people are really consumed with fear about it and looking for ways that they can protect themselves.
My greatest concern is I know of one patient who I've counseled. She is a bus driver who has done quite well after breast cancer chemotherapy. A bus driver still is exposed to a lot of people, even if they're wearing a mask. And I hope the people getting on the bus are wearing a mask. In DC, by the way, they've actually started where people only enter the bus from the back to actually decrease the exposure for the bus driver. I think people like her ought to be indoors and ought to be isolated. I am very worried. Now, I remember I once said we should tell people what we know, what we don't know, and what we believe, and label it accordingly, and question what we know more so than anything else. I don't know the answer to this, but my belief is that anyone who has been treated for cancer needs to try to avoid exposures as much as possible. And that includes avoid jobs that increase exposure to the public right now.
Okay, so if, as we move to sort of reopen the economy whenever that happens, and it sounds like, there are people pushing to have that happen sooner rather than later, and other people saying that that can't happen for some time. If what about your bus driver patient who doesn't have a job that can be where she can stay indoors? I mean, some of us have the luxury of jobs where we can still work from home and we can still be productive and we can still have an income, but not everybody does. So how do we help those people?
This gets directly into the issue of the racial disparities, the racial and socioeconomic disparities that we've been hearing about only recently with this disease, but we've been struggling with as a country since time immemorial. I would give that person disability compensation and let them retire from their job as if they were disabled. Unfortunately, I don't control the rules in this country, but I think that people who are immunosuppressed or that have had their immune system manipulated, that's virtually anyone who's received chemotherapy and most people who've received radiation therapy for cancer, those folks are putting themselves at risk when they're exposed to the population right now. I have data to show that they don't do well once they're infected. I do have that data.
Mm-hmm. For cancer survivors who are completed treatment, how should they think about regularly scheduled scans and testing and follow-up appointments? I know there's been a lot of movement toward telehealth, but you can't do a follow-up scan by telehealth. So how should they think about that?
Yeah, people who have non-aggressive tumors, these are the folks who have, other than the fast-growing lymphomas, other than the very fast-growing breast cancers. Most of those people, they should always talk to their doctor about this, but the doctor is going to, I think, explain to them that they can delay the every 3 month or every 4 month CT scan looking for relapse right now. The risk of them being exposed while they're out and about going to the doctor and the doctor's office, so forth, is such that those every 3 month, every 4 month CT scans for surveillance in most diseases, they can be put off right now. You can miss one. We'll catch up in July or August when things are a little bit better. The folks who have the things that grow fast, like the Burkitt's lymphomas that just went into complete remission in the last couple of months, who are getting CT scans every 3 months. They need to talk to their doctors. For them, I think it is worth the risk, and they ought to be getting those CT scans still. But it's going to depend on the disease. Most people can skip going to the doctor, and we have converted at Hopkins. Most of our outpatient follow-up is being done by video conferencing right now, and that's working out well.
What are the challenges to using telehealth? What are the things that you feel like you can't accomplish as well using telehealth? I mean, I think that could potentially be a big benefit to the expansion of telehealth, but also, you know, I was talking to a survivor yesterday who told me she had a couple of different telehealth appointments that were really not very useful for what she needed at that time. So what are the pluses and minuses, I guess, of telehealth?
You know, I see a small number of patients, but I learn a great deal by looking at their body language. I learn a great deal by looking at, I see prostate cancer patients by looking at their spouse when we're having a conversation. Tony Fauci says that we should never shake hands again in our society. I'm going to miss that tremendously. I agree with him, but I'm going to miss that tremendously. So I learn a lot just by seeing the patient that I don't learn with telehealth. It would be far worse with just a telephone, but the Zoom camera just doesn't do it for me, especially when you're talking about patients who are less literate or older patients who are less likely to tell you this hurts or that hurts. You don't get that from telehealth. And it's unfortunate. Maybe some of us can learn how to use it better right now, but I'm still struggling to learn how to use it.
Mm-hmm. We've heard about treatments being delayed or canceled, and you talked about the decisions in some cases to forego the adjuvant chemotherapy, and that patients are skipping appointments that are not absolutely necessary. How are patients supposed to think about what is absolutely necessary? And what is your advice to someone who learns that their adjuvant chemotherapy is now not recommended, which gives them a higher risk of recurrence? So how do you advise them?
I'm hoping that you have a good relationship with your doc and you can talk to him or her. And there are some people whose adjuvant chemotherapy is going to reduce your risk of relapse by 10%, and maybe your risk of getting COVID-19 is high and not doing well is high, and so 10% reduction is not worth it. There are other people where adjuvant therapy is going to reduce their risk of relapse by 40 or 50%. And there are some doctors who are really trying to talk to the patient over Zoom or WebEx and trying to figure out what the patient's values are. And there are certain patients who should get the adjuvant chemotherapy right now, and we are giving adjuvant chemotherapy. But there's a bunch of patients who can forego it.
Great. That's helpful. I think making sure that it's still an individual decision and not a blanket recommendation is really important.
For breast cancer and for colon cancer, we actually have really good computer programs where we can put a person's age and some things about their pathology into the program. And we can say, if we give you FOLFOX, your chance of cancer coming back is X. If we don't give it to you, your chance of cancer coming back is Y. Is X lower enough that you're interested in the chemotherapy?
So can you talk a little bit about patients who are in treatment for metastatic cancers, and how is this affecting their treatment? And also, I'll let you answer that first, and then I have follow-up questions.
Yeah, many of the metastatic patients are still getting their chemotherapy and still getting treatment, because the feeling is that if we were to let the disease grow during this period of time, it would be inappropriate. When it looked like the shutdown of the economy would only be 2 or 3 weeks, some of us were delaying that next cycle of chemotherapy. But now, quite honestly, we need to have our economy shut down into June 1st, at least, probably further. now that it looks like we're going to be going a much longer period of time, most oncologists are electing to give chemotherapy to people who have metastatic disease, unless there's an occasional person, I see this sometimes with breast cancer especially, who has metastatic disease, but their disease is quiescent. Yes, it is metastatic, but it is not growing. That person might benefit from observation right now as opposed to continuing some type of chemotherapy.
So should those in treatment or in recent treatment be wearing N95 or N99 masks, especially if they're going to their treatments, and would it help protect them?
It's called an N95.
Okay.
The problem with an N95 mask, and actually I saw a whole bunch of people in the area where I live walking around wearing them today, is when I was fitted with an N95 mask, they put the mask on you, figure out what size you need to wear for face, and then they spray this sweet smelling stuff, and they ask you, can you smell or taste the sweetness? And if the answer is yes, the mask is not fitting correctly. And you're not allowed to wear beards with an N95 mask, for example. And so my concern is, I like the idea of cancer patients wearing N95 masks. This is Otis speaking. This is not CDC policy. I like the idea of cancer patients wearing N95 masks, but on the other hand, I'm worried they're not going to have them fitted correctly. And number two, I'm worried when we start saying wear masks that's going to cause people to, I hate masks, and I'm always fiddling with them, and moving my hands up around my face actually puts me at greater risk than wearing the mask. And so I like the idea of an N95 mask if the person's wearing it correctly and if it doesn't cause that individual to start fiddling with their face.
Okay. So there's been a lot of talk about in-home infusions for some cancer patients, and anecdotally we've heard some mixed views from patients. Some were in favor of it because it would help them manage their risk, and others had concerns about safety. We also heard mixed views from providers from a safety perspective. What are your thoughts?
Certain drugs, I think, can be administered at home by usually a visiting nurse or someone who is skilled at doing that sort of thing. Certain drugs, I think, ought not be administered at home. For example, the taxanes, Taxol and Taxotere, we have a good 3, 4, 5% of people who get those drugs have an allergic reaction to them, and I would want them to be in a medical environment that was able to give them more than just a shot of epinephrine for wheezing and shortness of breath. So there's certain drugs where I think home infusion is fine. There's certain drugs where I would rather not see home infusion. I think that person ought to come to the hospital if they need, or to the doctor's office if they truly need that drug.
Thank you.
Also, by the way, one other thing, keep in mind, many of these chemotherapies are themselves carcinogens, and so I'm going to be concerned about exposure of people in the house to the leftover drug and that sort of thing. We have to be very mindful of that too.
That's helpful. So even as we're talking about risk, we're getting a lot of questions from patients about their specific care and how it may be altered or interrupted due to the coronavirus and about their specific risk. Can you give some advice to cancer survivors about how to communicate with their doctors during this time?
Yeah, I actually think, I'm heavily into being open and honest. Doc, this is what's on my mind. First thing that's going to be on a lot of people's mind is my cancer growing while I'm not getting treated? Am I going to be worse off because I'm not getting treated? And I'm really in the open, honest communications. If you can't have a good, open conversation with your oncologist, perhaps he or she should not be your oncologist. Unfortunately, this is a fine time to change docs.
Right. Thank you. Okay, I want to turn to rationing of care. You already talked a little bit about it, but I want to address some additional questions about it. So, we're hearing from some metastatic patients who are hearing about rationing ventilators, and that if they need care, they shouldn't admit that they have metastatic cancer. Are these types of decisions happening anywhere yet in the United States, or are they just a grim possibility that we're preparing for?
I am not aware that rationing of ventilators is happening in the United States at this time. I am aware of some emergent transportation of ventilators from one hospital to another happening in New York City, so that there was not a shortage of ventilators. I really do encourage people to be very honest with their healthcare providers about their past medical history. Some elements of their past medical history are going to be incredibly important. Certain drugs I would not use, for example, in people who have been treated for metastatic cancer, even people who've been treated to complete remission for metastatic cancer. So please be open and honest about that. I hope nobody ever has to go onto a ventilator, but I am not aware in the United States at this time of anyone being deprived of a ventilator because of they wanted to go onto the ventilator and they had a past medical history of something, or they wanted to go onto the ventilator and they were of a certain age.
Okay, and then a follow-up to that is, we talked about this last week with you, and when we were asking you for some guidance, is that we know that some, in planning for the potential of these shortages of ventilators, some institutions have had guidelines that include terminal cancer as in the group of people who would be offered supportive care. But as we all know, many people live with stage 4 cancer for many years and can be very stable with that, but yet would still consider that to be a terminal cancer. You told us a different definition of terminal cancer. So can you talk a little bit about that? And then should we be advocating for a more specific guidelines rather than this broad brush of terminal cancer?
Terminal cancer in the mind of an emergency room doc, I believe, is someone who has cancer and is going to die of that disease over the next 6 to 8 weeks or sooner. It's distinctly different from stage 4 disease. And I say that because one of my dear friends is a patient that I took care of in 2002, 2003, and we diagnosed her with metastatic breast cancer to brain back then. And I still talk to her. She's living with metastatic disease now for 18, 19 years. Yeah, so there's a difference between stage 4 and terminal. Now, there are some people who have stage 4 disease who are terminal. There's some people who have congestive heart failure who are terminal as well. But, and by the way, we have really good data to show that people who are very sick, who go onto the ventilator, going onto the ventilator, by the way, is not a pleasant experience at all. Many people who have come off of it have described it as being waterboarded. I've actually had patients who said, I never want that experience again. Don't put me on the ventilator again. But many, keep in mind, the people who they are saying don't put on the ventilator are the people who are very likely never going to come off the ventilator alive.
Okay, thank you. I still have a lot of questions, and we have some great questions coming in. So I'm going to turn now to a few kind of epidemiological questions and public health questions. So do you recommend cancer registries collect data for delays in cancer treatment or data about cancer patients with COVID-19 that might help us then later assess what the impact is down the road?
Yeah, by the way, the only advantage to this whole mess with COVID-19 is people now know that epidemiologists are not skin doctors. I would love for registries to collect data on has the patient been infected with COVID. I would love for them to collect data on has there been a delay in treatment. The reality is that the way these registries collect data, it's going to take them 6 months to a year for those questions to get into the database of questions that are currently being asked. So I don't anticipate that's going to happen. Most of the registries right now, by the way, collect treatment planned over the next year after diagnosis, and they don't necessarily collect the treatment received. We can go into some of these electronic databases like Epic and retrieve some of the data that you just talked about. It doesn't have to go into a registry per se.
So how will we then be able to measure long-term the impact of COVID-19 on cancer population? And will there be a measurable shift in the stage at cancer diagnosis or in recurrence rates?
We're going to see that from the registries for sure, and we'll see that from the registries within the next year or two, I suspect. The other thing that I'm very interested in is to get a cohort of patients, both those with cancer, with various types of cancer, and those without, who do well after being infected with this disease, and follow them over the next 10, 20, 30 years. As I noted earlier, there's been a correlation between having the influenza from 1917 to 1919 and as a child, and then having Parkinson's disease in one's 50s or 60s. You know, that was from long-term cohort studies. We didn't even call them long-term cohort studies back when they were started in the 1920s, but that's the sort of thing that we need.
Okay, thank you. I want to turn now to talking a little bit more about disparities. You did talk about some of the disparities in outcomes, and there's been a lot of reporting in recent days about higher death rates for African Americans diagnosed with COVID-19. Dr. Fauci acknowledged these disparities in the daily White House briefing earlier this week. And also, there's been a reporting that the death rate has been higher for Latinos in New York. So what do we know about the reasons behind this? Is this just a function of the disparities we already see in our in cancer care that are now coming to light in a much more public way with this? And what can be done in the short term? I know some of these are factors systemic to the healthcare system, but are there any things in the short term that could be done to make a difference to stop the spread in African American communities?
Yeah, I think Dr. Fauci was incredibly appropriate in talking about those disparities. I think the only thing we can do right now is try to make sure that every human being, no matter what their race or ethnicity or credit score is, gets adequate care for all things. One of the problems I have is, the president said we're going to pay for everybody's COVID care. Well, what about their diabetes and congestive heart failure underneath that, that's actually going to increase their risk of, one, getting COVID, and two, not doing well with COVID as well. And so I'm really into giving adequate care to everybody. I'm very concerned, by the way, the incidence rate in poor people is probably lower than the incidence rate in middle class people, because poor people don't have a doctor who can. I ran into this just yesterday. Somebody called me and asked, would I write an order for them to get tested for COVID-19? You have to have a doctor's permission to get tested. Poor people don't have relationships with doctors. They may have a relationship with a clinic that's giving them their diabetes medicine, but that's not the same as having a relationship with a doctor. Right now, I think the most important thing to do is to try to give everybody the care that they need. I'm going to look into my crystal ball and predict that we're talking about disparities in Blacks and Hispanics in the big cities right now. 2 months from now, I think we're still going to have this problem out there, and we're going to be talking about the disparities in poor whites in the southern United States, because we've had a couple of states, Georgia being one of them, where the governors have made some absolutely stupid decisions in delaying closing things down. And we're going to see spread into the white, poor, rural population in Georgia and in Arkansas and a couple of other states.
Okay, so it sounds like a lot of it's, it's hard to break down kind of what percentage of the disparities has to do with access to care versus underlying health conditions versus jobs that require you to not be socially distant. It sounds like it's a mix of all of those.
It's a mix of all of those, and that last part you just said is so important. The people who are having to work right now are the folks in the grocery store, the folks who are driving the buses, the folks who are driving the cabs, the folks who have to make a living with Uber and Lyft. There's a lot of jobs that are out there where they can't sit in their, home and Zoom all day. And those are poor folks who are more likely to get exposed. And then, of course, those are the same poor folks that we're talking about who are more likely to have comorbid diseases already.
Right.
We're not going to be able to put a patch on the whole health disparities problem right now just because of COVID. But my one effort to deal with it is just try to get every human being the care every human being needs.
Right. Okay, now I'd like to turn to clinical trials. So we know that clinical trials have halted enrollment. Some clinical trials have, that some research labs have been closed. Some cancer researchers are being pulled into COVID-19 research. So tell us a little bit about the current state of cancer research, and then what is it going to take to recover after COVID-19 is no longer an emergency?
Yeah, almost all the cooperative groups have shut down accrual to most of their trials. People who are going on the trials for very aggressive cancers like the aggressive lymphomas and leukemias are still being enrolled, but the adjuvant therapy trials and so forth have been shut down. At the major universities, the laboratories have all been shut down. At Hopkins, we're allowed to go keep our cell cultures alive, keep our lab animals alive, but we're not doing any cancer experiments, at least for the time being. So we're all on ice. This is going to set us back for at least 3 to 4 months after the reopening. If we're shut down for 3 months, this is a 6-month shutdown. This is going to set us back 6 months. This is a huge problem for all of cancer. There's just no way of getting around it. I have no better answers. We do need to be in a position where we can start up as quickly as possible afterwards. I have yet to see nurses and clinical trial specialists being laid off or anything by any of the major hospitals, but I'm worried about the hit that the major hospitals are going to take over time, and that could even cause even more harm to what's going on. This is bad. It's just bad.
And is there anything that we as patient advocates can be doing to advocate for that when the time comes that we can reopen? I mean, I think we feel a little bit helpless here. We know it's bad, but what can we do to help?
Well, I think that the try to make sure that your congressmen and senators have in their mind that they need to support the hospitals. They need to support the research infrastructure. It's not just cancer, it's HIV, it's cardiac disease, it's a number of other diseases as well. Make sure that the congressmen and senators have that in mind. I've heard a lot more about bailing out the restaurants than I've heard about bailing out medical infrastructure. I support both, by the way. I support bailing out both.
So I'm going to ask you to get your crystal ball out again. How long do you think the shelter at home and social distancing will last? And what do we do when we do reopen the economy? I know you talked about, potentially cancer survivors that are at high risk going on disability, but what else can we do when we get back to these, when we reopen the economy and have different policies and procedures about who can go back to work and what they need to do to protect themselves and others when they go back?
I don't know how it's going to come down. My belief is that we should start opening up the economy again in phases starting around June 1st. That's what I believe we should be doing. Unfortunately, if we had shut down the economy better, we could have opened it up earlier.
Yeah.
But assuming that we keep it shut down now, I think we can open it back up around June 1st, but it's going to be in phases. And I don't think we're ever going to be the way we were 3 months ago ever again. I honestly do believe that we're going to have some social distancing in June and July. I honestly believe that we're never going to be shaking hands again.
Really? I know we have a lot of people on from state cancer coalitions, and they've asked what could they be doing to help in their states?
Again, making sure that local legislators understand this problem that cancer patients are going through, that cancer research is going through. We talked about the health disparities. Please try to make sure that your local legislators understand that the most pressing issue in the United States, in my mind, is how do we give adequate care to every human being, and that adequate health care is a human right and it's not a right of the rich. It is a human right. It is a basic human right. Some of the work that I've done recently talks about how we've had a 65% decline in colon cancer death rates in certain states and a 15 to 20% decline in other states. The states that have had the 15 to 20% declines are the states that don't appreciate health. They've not expanded Medicaid so that everybody can have some access to care. Keep in mind, they didn't appreciate health before the Affordable Care Act. Those are the states that have the lowest taxes on tobacco and have the highest smoking rates as well. And so the local state cancer coalitions, please try to make your politicians appreciate not just cancer health, but global overall health.
Okay, thank you. I have one last question for you. And this is the one I keep coming back to in our staff meetings and in my own life with my kids is like, what do you see any silver linings here? And how when we come through this emergency, any silver linings that will help the cancer care, cancer research, the cancer experience for cancer patients?
Yeah, the medical community has come together and been united in a way that I haven't seen. We didn't have this when I was a young doc when we had HIV come forth in the 1980s. We were not united the way we are today for HIV. I think a whole bunch of doctors went back and read what they put in their essays that they wrote when they were applying to medical school. And a whole bunch of us actually realized why we really should have gone into medicine. I think we've got a much greater respect for nurses and the laboratory personnel, even the folks who clean the floors in the hospital. I was very moved the other day. I heard that the chair of ENT at the Cleveland Clinic found that he couldn't be helpful in patient care. And so he went and got a mop and bucket and was mopping the floor with the folks from housekeeping. I think the human aspect has come out of a lot of us. So yeah, that's perhaps the one big positive.
Great, thank you. And I think along with that, how much the American public has really rallied behind and supported and honored the healthcare providers who are on the front lines of taking care of COVID-19 patients. Thank you so much, Dr. Brawley, for joining us and for shedding light on these important and difficult topics. As we promised, you tell it like it is, and it's not always easy to hear, but it's important to arm survivors with knowledge and truth, and we're really grateful to you.
Thank you for all that you do.
Thank you. And I'm really pleased to announce that our next webinar will be next Tuesday, April 16th at noon. Dr. Imani Price will join us to talk about how cancer survivors can navigate stress and anxiety in these uncertain times. Dr. Price is a licensed psychologist at Women's Inner Fitness and Wellness Center and serves as vice chair of the board of directors at Breast Care for Washington, D.C. So look out for more information about that webinar, the next in our series. Thank you again, Dr. Brawley, and thank you to everyone for joining us today and for your wonderful questions. We really appreciate you participating today.
Thank you.
Thank you.
In our next podcast, we'll talk with Dr. Imani Price and a group of cancer survivors about how to navigate stress, anxiety, and grief in these uncertain times. Dr. Price is a licensed psychologist at Women's Inner Fitness and Wellness Center and serves as the vice chair of the board of directors at Breast Care for Washington, D.C.